Welcome, everyone. My name is Dr. Mohini Rawat. I'm president of American Academy of Musculoskeletal Ultrasound. We have organized this mini webinar series where I'm going to be talking about point of care ultrasound and its application in various joint assessment. Today's focus is going to be on shoulder. So the goal is to provide you with information on how point of care ultrasound, which is also known as POCUS, can be used in assessment of different joint regions. So POCUS in shoulder pathology can be used as extension of your clinical examination. Now, some of you may be new to ultrasound, and I have included some background information on ultrasonography. Ultrasonography is a diagnostic tool that uses sound waves, and it's one of the common imaging modality we use worldwide and it is used in various regions of the body. It's not just restricted to musculoskeletal. In fact, its first use was more elaborated, and it's used much more commonly in OBGYN. And most of the people, when you tell them that about ultrasound, they associate ultrasound examination with the OBGYN type of ultrasound. So it uses the principle is the same. It uses sound waves. It's safe because there are no radiations, no exposure to any radiations. It's sound waves, which are used at a frequency depending on how deep or superficial you want to go to that tissue. And it's reliable. It has some user dependency, but it's a reliable imaging tool that can be used non-invasively. And the most important part, it's portable. So it's a great tool in the hands of clinicians where you can perform clinical assessment depending on if you are as a consultant, you're going from place to place, you can carry these ultra portable units, which can these days fit in your pocket. So anywhere from portable to ultra portable devices are available, and with time, the probes are getting better, the resolution is getting better, and we have really exceptional resolution with ultrasound probe these days. And it's expected to improve with time, as with any technology. Okay, so POCUS. So POCUS stands for point of care ultrasound, and it's a revolution in patient care. And the reason is because it's an assessment that you add, it's a tool that you add as an extension of your clinical examination. So you are assessing a patient and you have certain set of diagnostic criteria, and you have differential diagnosis. You need to rule out certain pathology, and you need to rule in certain pathology, or come to a conclusion. If you are going to go one way or other, you can add point of care ultrasound at that point, and that can enhance the patient service because you'll have much better accuracy because of greater confidence in your decision making, because you're able to see the structures which you were not earlier with just assessment with special test. And I'll use some examples later on to show you how when you use clinical examination special tests, especially for shoulder, we have an impingement test. When you add ultrasound, how that can give you more information, gives you a lot of important information about the structure, how the structure is moving. So it's not just static. You also learn about how that structure is interacting with the tissue around it. And it's being compared to introduction of stethoscope in the 19th century. So it is a big revolution in neuromusculoskeletal assessment. It's easily accessible and something that doesn't really involve like a lot of infrastructure and a dedicated space. It can fit in your pocket. So it really enhances your diagnostic ability, and you're able to add this to your diagnostic tools. Now, with point of care ultrasound, although it may sound like it's a new tool, which it is, But when you think about what you're trying to do with this new tool, it's not something different. You already do that in your regular practice as an extension of your clinical examination. You just add this tool. When you're assessing a patient and you're checking their active or passive range of motion, in your mind, you're already thinking about how that structure is extending, if it's contracting or it's lengthening. Now, with the same thinking where you're thinking about anatomy in 3D as you're moving the body part or the patient is moving their body part. Now, if you add the second set of eyes and which can see inside the body, that would be wonderful. And that's what point of care ultrasound does. It gives you more information, and it gives you this view of inside the body, how this structure that you're assessing using special tests, or sometimes maybe just active or passive movement, how that structure is interacting. And with the case example that I have coming up next, you will be able to see how when you assess a patient and a range of motion is restricted, it can be due to various reasons. And unless you have some type of imaging, you cannot just rely on physical examination or special tests to really differentiate between different pathologies, because it can be confusing no matter how good of a clinician you are. So before we do that, for some of you, if you're not familiar with grayscale images, I wanted to show how different tissue appears on ultrasound. So muscle appears hypoechoic. When we say hypoechoic, it means it's darker. So here you can see on the left side, this image is long axis. So the muscle is in longitudinal view. So you can see the striations, which is the connective tissue network framework of the muscle. On the right side, we have short axis view, where you have the transverse view. These are the ultrasound terminology. We use long and short axis. Again, you can see the connective tissue framework, but it shows in a short axis or a transverse plane of view. Tendon on ultrasound, they appear hyperechoic, which means bright. So if you see the top image, that's the orientation of the tendon on the left, long axis. So you're along the fiber length of the tendon. And so you can see this linear collagen arrangement within the tendon. If you rotate your probe and from long you become short, the tendon appears as a bristle-like. It looks like a stack of spaghetti. If you see it from one of the ends, it looks like that. There are bristles in that area. So that's the normal appearance of tendon, bright, but with some linear echoes within it in long axis, and in short axis, those linear shadows, if you cut them in half, it looks like a bristle. So that's a bristle-like pattern. Ligament is also very similar to tendon. It has this bright appearance and again, these linear echoes because of collagen arrangement. So in this case, we are showing the MCL of the knee. Bone appears bright and is always the last interface that you see because it's a good reflector. It reflects most of the ultrasound back to the probe. So you're not able to see anything beyond that, beyond the bone. So bone is the last interface. If your probe is in a region of the body where you have bone, you don't see anything beneath that. So that's an important point to note. So if you see some echoes beneath the bony landmark, you know that you're seeing artifacts. You're not seeing the anatomy beneath the bone. Now, nerve appears as a honeycomb or starry night in short axis in transverse view, as you see in the bottom image. On the top image, you can see the linear. Now, it also greatly depends on the type of frequency of the probe that you're using. It can give you greater resolution. If you go somewhere like 12 megahertz, it may not show this nice honeycomb as you see right here. It may just show starry night appearance. But all in all, it's going to be some type of speckle, honeycomb or starry night pattern within the nerve in short axis, and some kind of linear striations in long axis. Because again, the nerve is arranged in a way that there are fascicular groups inside the nerve. So that shows up as ultrasound image as grayscale, honeycomb, or starry night. And the cartilage, it depends which cartilage you're looking at. Hyaline cartilage appears dark, so it's anechoic, as you see this darker band lining the femoral trochlear cartilage line surface of the femur. That's what you're seeing on top. On the bottom, you can see this is the meniscus. So that's a triangle, and it's hyperechoic, which means it's bright. So in shoulder, this is the labrum. On the lower left, you can see this image, and I hope you can see my cursor. This triangle that you see is the posterior labrum. So labrum, meniscus, they're fibrocartilage. They're going to be bright on ultrasound. As opposed to that, hyaline cartilage, which is going to be darker on ultrasound image. Now we also have color Doppler ultrasound capability in all the machines that you use for ultrasound imaging. And that gives us information about the physiology of the tissue. So you can see nearby blood vessels, as we can see in these images in short and long. Or you can also see some type of pathology like neoangiogenesis, which is very common in tendinopathy. So that was the background on how different tissue appears on ultrasound. Now let's move over to our shoulder region, which is the focus of today's POCUS talk.
That's right for you. So you can start spending less.
So shoulder, someone's mic. All right, so let's go back. Okay, so shoulder dysfunction is one of the most common reasons for patients' visit to primary care physician and physical therapist. There are 4.5 million visits per year related to shoulder pain in the United States. We assess shoulder with our clinical test and physical examination, which is great. We are not going to take that away. We need to do that. But clinical test and physical examination may not be enough to differentiate a wide range of pathologies, especially in shoulder and neck area, because of their confusing presentation or their similar presentation. So when we use these special tests, especially in isolation, they do not have great diagnostic accuracy. So as you may know, we have clusters, these diagnostic clusters, and that applies to even other joint regions where we use this cluster, and that increases our accuracy for diagnosis of a specific condition. So this accuracy improves when these special tests are evaluated in combination, but in certain cases that may still not be enough. So in those cases, you will greatly benefit from imaging tool, especially ultrasound imaging, which is in a way it's same like what we do with special tests. It's just with extra set of special eyes where you can see how that structure is interacting. And I have a case example coming up to demonstrate this point, how certain conditions can present the same on clinical examination, but with ultrasound, it can differentiate between different pathologies with similar presentation. So if we look at the special test and look at their sensitivity, specificity, and accuracy, you can see there are some different numbers out here. So in general theme, you see more like 50s, 60s, and 70s in sensitivity, specificity, and accuracy. So you have some chances of finding if this is a true impingement or if it's a full thickness tear or partial thickness tear based on your clinical test, which includes lift-off test or MTCAN and Hawkins-Kennedy for impingement and nears. But the presentation can be similar. And what if you are sure that this patient has some type of impingement, but what is impinging? So that can be assessed with ultrasound very well. You can tell which tissue is impinging, and that may have greater clinical significance. It may change in some cases the management of the patient. Now, looking at the specificity, sensitivity, and accuracy of ultrasound, the numbers are better, especially for full thickness tears, and they are in 90s and in some cases reaching 100. It's especially true when these studies use arthroscope or surgery as a gold standard. The numbers are not as good when MRI is used as in comparison. And the reason being because you're comparing against an MRI, which is also a static way of assessing a structure. So you are in the MRI scanner and you're static. There is no way of moving the limb to dynamically assess if how the structure is moving. So some of the pathologies can be missed out. Now, ultrasound is rapidly growing and becoming popular as point of care assessment tool, which is what POCUS stands for. When you use it and it's appropriate, you can effectively eliminate unnecessary costly imaging, which can include MRI and X-ray in some cases, and it can provide insight into pathophysiology of the shoulder. And of course, it's not replacing anything. It is definitely is an extension of what you already do in your clinics. But before you send them out for MRI or any other costly imaging, ultrasound imaging can be done as an extension of your clinical exam, and you can study the structure and understand the pathophysiology that's going on there. So let's use an example of a patient who's not able to elevate the shoulder. So this patient presents to you and they're not able to lift their arm. And so that's their presentation. How are you going to assess that with your point of care ultrasound tool? So let's say you did everything. That's your interaction with the first encounter with the patient. You did your standard history taking, system review, range of motion assessment, special test. And because they are not able to lift, so their active range of motion is 0, passively, you may or may not be able to go beyond 90. I'm going to use different scenarios. In some scenarios, you can passively move, and in some scenarios, the passive movement may be painful. So what can we do? Now, like I said, ultrasound is not just static assessment where you just take snapshot and image. You can also move the shoulder. You can dynamically assess how supraspinatus is moving under the acromion. So let's look at the normal shoulder. If you put a probe over the lateral aspect of the shoulder, so I have a shoulder joint right here. Hopefully you can see here. So this is the anterior side. As you can see, this is the coracoid process. That's the GT, humeral head, and this is acromion. So this is the acromion, and that's the GT. So you know the supraspinatus comes out from under the subacromial arch and it inserts on the greater tubercle. So when I cannot move, this one is fixed. So when we are elevating the shoulder, you move the humerus, right? You roll it and elevate. And as you're doing that, you can see the sliding of the supraspinatus under the subacromial arch, and which is what we expect when we are doing the physical exam or assessing them with active range of motion. So you see the sliding of the soft tissue structures underneath this acromion, which is the subacromial arch. So you should see normal sliding of the structure as the patient elevates the shoulder. So here we have a normal shoulder. This is the orientation. We need acromion bone in the view. We need the greater tubercle in the view, and we need the supraspinatus in the view. This supraspinatus tendon, just above that, you see this darker band. That's the subacromial bursa. In normal states, you don't see it, or you may see minimal fluid, as you see in this case. It's normal. Now let's check it dynamically. So this is a clip. You can see acromion on the left, greater tubercle on the right, and just a small portion of the supraspinatus right here. So now we ask the patient to elevate the shoulder and see how the supraspinatus is sliding under the acromion. Now everything is stuck under, and I'm going to point out this tissue that became really big right there, it's deltoid. So the first 15-degree movement comes from supraspinatus. So you see supra movement. As it slides smooth under the acromion, you see the deltoid kicking in. So this is what we expect in a normal shoulder elevation. So let's play it back. Acromion on the left, GT on the right, and you can see this supraspinatus tendon showing up right there. You can see the deltoid on top, which doesn't look as thick, but as we elevate, there is smooth sliding in. And see how the size of deltoid is increasing because it's contracting. So you're seeing concentric contraction of deltoid right here, and you're seeing sliding of structures underneath the acromion. So this is what we see in normal shoulder where there is no impingement, no pain, and they're able to lift the shoulder, elevate their shoulder up. Now, if someone has difficulty lifting the shoulder up, I'm going to show you 3 scenarios that you can pick up with point of care ultrasound. So let's look at scenario number 1. Now look at what is different here from the previous images. We have greater tubercle right here. We have supraspinatus right here. And above that, we have this black band, which is effusion of the bursa. So that is a significant amount of fluid sitting in the bursa. It's an extra structure just above the supraspinatus. So you have supra, and above that you have bursa, but everything is underneath the acromion. So if you have this much of fluid pressure in that area, it's going to cause restriction. So showing you the 2 plane of view of the same patient's shoulder. So you can see supraspinatus, and you can see the bursa over the long axis of the bone, of the tendon. In short axis, you can see the same. The entire bursal plane has effusion, and it's been lifted up, distended. When you ask the patient to elevate the shoulder, it doesn't go all the way in. So this is acromion right here, and you can still see this is the end range, as much elevation they can give you, maximum range. And you can still see the tendon, and the bursa is showing more fluid. And the reason, because when you push them or they try to give you as much movement as they can, the acromion, overlying acromion, puts pressure on the bursa, and it's like squeezes the fluid in downward direction. So it gets collected in this area and causes a physical block in the movement. So that's a lot of effusion. So now this fluid from subacromial has been pushed down into the subdeltoid portion of the bursa, which is extension of the same. So that's one scenario where a patient may not be able to elevate, and when you really try hard with active or passive, the fluid may push more under the subacromial arch and down into the subdeltoid region. Now let's look at the second scenario. Now here we have acromion on the right, and this is the humerus. We are not able to see the greater tubercle very well right here, but look what happens in this image. Everything is drifting towards one side. Now this is the clip, but if you see this patient in reality, you can in a way guess what they're doing. They're doing the lateral deviation. So there is no movement of the shoulder glenohumeral joint here. The entire movement is coming from compensatory movements, which is lateral deviation and some deltoid firing. So here, these are altered mechanics where you are not going to see that smooth gliding of the supraspinatus under the subacromial arch. And there is depression of the humerus, which creates this abnormal bony appearance, which you normally do not see. So that one point that cannot be emphasized enough, to be able to see and pick up these changes in the tissue and a tissue appearance, you have to know what normal looks like. Normal is very important. So if you start your journey of learning ultrasound and use this as an extension of your clinical examination, the most time that I recommend that you have to put in is knowing normal. And there is no one normal. You will see the normal will change from patient to patient, person to person. And it also changes from as we age. So across a lifespan, we have different normals. So pediatric normal is different from early adulthood to mid-adult and elderly. So you have to know the normal very well. Okay, so that was scenario number 2 of someone not being able to elevate the shoulder. Now let's look at the last scenario, the next scenario. Here, this is a patient who presented with 9 on 10 pain, couldn't move the shoulder, passive or actively, no shoulder elevation at all. Doing ultrasound, when we did the ultrasound, we found this bright structure, which looks like it's bone in short axis. So there is deltoid overlying there. Under the deltoid, you can see this bone. So someone, if they don't do the second plane of view assessment of this tissue, you can say, okay, this is the humerus and we have overlying muscle. So probably it's a full thickness tear, and which makes sense. You know, we are all biased, especially when our clinical assessment is suggestive of full thickness complete tear. Sometimes we are very fast to conclude that as full thickness complete tear to confirm our biases. But you want to do two planes of view assessment, and you also want to do a dynamic, whatever minimal dynamic movement you can get, either passive or active, you want to add that. So long axis view again gives you this bright structure, but you can see it doesn't line up with the rest of the humerus, which means it's not in the same plane. So in long, the bottom right image is showing you this view right here. And I'm going to flip it actually. So it shows the bone right here, and it shows the tissue over to the left side of the screen right here. My camera is flipped, so I was trying to align it with the bottom image. So on the right side, this bright interface is the humerus, and supraspinatus is right here, but it looks bright, which means calcification. So there is massive calcification in this tendon. It has covered the entire supraspinatus. Most likely, it's also involving the bursa, overlying subacromial bursa. So when you have that calcific deposit, it can be painful, and it can be something that can restrict the movement. So which explains why patient has moved and they're not able to move. And this can be excruciatingly painful. So these are the three scenarios where point of care ultrasound can really delineate and really give you better understanding of what's going on with the tissue and what the pathology or pathophysiology of the tissue is. Now, other than that, you may also see calcification in small chunks or like in small pieces, like in this subscapularis tendon. We can see calcific deposit on the distal portion of the tendon. When you go across the tendon width, you can see these cluster of calcific deposit. This is something that can restrict someone's internal rotation, because you have subscap coming from here attaching to the lesser tubercle, and with internal rotation it can hit against the coracoid process if there is significant calcific mass or deposit there. And this can again be clinically assessed with point of care ultrasound dynamic real-time assessment. There are other pathologies other than partial tear, full thickness tear, and calcific deposit. You may see tendinosis or tenosynovitis if tenosynovium is present, like in long head of biceps tendon. You can see a darker tendon. Remember, tendons are supposed to be bright, but this one is dark. And in short axis, you can also see this hypoechoic ring around it, which shows color Doppler activity on color ultrasound. So this means that this tendon is showing some fluid around its sheath, and there is some new angiogenesis there. Ruptures, although they are clinically evident and you can clearly see it, but you can assess if it's a full thickness complete or there are some fibers still intact. So this is example of a full thickness complete rupture of long head of biceps tendon. You can see it's torn and it's retracted. This dark signal that you see right here is a hematoma. A bottom image is showing you a normal healthy tendon. So these are some of the examples where you can see how ultrasound can really give you more confidence in your differential diagnosis and knowing the condition better. In some cases, you may need more than conservative treatment. So it increases your confidence and also the confidence that patient shows in the care provided. And we have studies reporting that when you add point of care ultrasound to your regular clinical assessment, patients, they report that they are better able to understand the problem, they are more reassured, and they are able to manage the problem just because they understand it better, because you have explained it to them and they see you're more involved, so they have greater confidence in the care provided. So there is greater satisfaction with the care provided. So I'm going to conclude my POCUS talk for tonight right here. I'll take any questions if you have. And also wanted to point out that we have online module. If you want to learn the shoulder region, we have a module where we cover normal scanning protocols and sonopathology, and also provide you some information on some of the pathology features of some conditions that normally you see in day-to-day clinic. More information can be found out online, and I'm happy to take any questions you may have now. Well, if there are no questions, then I'll see you next Monday, same time, 6 p.m. Eastern, and we will cover knee joint the next week. Oh, I see something. Hold on. Oh, thank you. All right. Thank you very much for joining tonight, and I hope to see you next week, Monday, 6 p.m. Good night, everyone.